Welcome, everyone. My name is Dr. Shirin Towfigh. Today is another episode of Hernia Talk Tuesdays. As you know, every week we gather together and get all your questions answered in a live format, anything that has to do with hernias. This is currently being simulcast on Facebook Live and as a Zoom. And afterwards, I'll make sure that you all have access to the videos to like and share on YouTube. You can also follow me on Twitter and Instagram at HerniaTalk, where I will also post links to the YouTube channel. So today we have the lovely Dr. Michael Rosen. He is a hernia surgeon, the chief surgeon and most senior surgeon at Cleveland Clinic for their hernia center. Do you actually have a hernia center? I forgot to ask. Yes. Yep. So Dr. Rosen I've known forever. He's past president of our American Hernia Society. He's very well known amongst all of us throughout the world for hernias. He's, I think, one of the tallest surgeons we have. So you always stand out from that aspect. You're also, I'll tell you guys, you'll learn it in the next hour. His speech is very entertaining because he'll just tell it like it is. And from what I understand, he's super excited to interact with patients. He's always had that aspect of him. And so thank you, Dr. Rosen, for joining me.
Well, thank you very much. Like you said, I'm really excited to be here, and I appreciate the opportunity.
So we already have people logging in from as far away as Mexico City. We also do get people from Europe that come in. The timing's a little bit off, but let's get started, shall we? I'm going to go straight to questions.
Great.
All right, let's just start with some definition. What is a giant hernia? Because that's really the topic of interest for today. And what is your definition of loss of domain?
So these are great questions. In fact, when I saw the title of this talk, I was a little bit like, I wonder exactly what this entails. So I think, probably the most honest answer to that question is, like so many things in hernia surgery, we don't have great definitions and we don't have standardization. And so those type of things really limit our ability to communicate kind of on a higher level so that everybody really understands what we're talking about. And I think that the struggles with that, a lot of us as surgeons try and use words that just, are easy to understand and everybody can grasp to understand what we're talking about. So I think if you if you step back and say, okay, well, a hernia obviously just means there's a hole and there's something coming through there.
Right.
And, what makes it giant? Well, I think there's, two big things to think about when we think about what is a giant hernia. I think number one is what are the challenges for the surgeon? And then number two would be what are the challenges for the patients, not only living with those hernias, but also overcoming the surgical procedures that are necessary to try and correct those. So I look at kind of giant hernias, maybe as a broader term, complicated hernias, are things where the hole is very large. So patients tend to lose a lot of their core function of their abdominal wall, and typically the muscles that help you digest food, that help you take deep breaths, that help you move your bowels, they're gone. And so there's a lot of quality of life issues that go along with not having that. And there's a lot of technical challenges that come with, trying to get all that stuff back together, get all the insides back inside, and deal with all those things. So I think, a giant hernia to me just means something really big. It's going to be a big physiologic strain for the patient.
Yeah.
And then I think it's also something that the surgeon kind of, if they feel like it's giant, they need to be prepared to make sure they have the skill set, the support staff, the right location to kind of take care of all those. And I'd probably say, the same thing for the loss of domain question. Just, in general, when we think about domain, it basically just means, your insides are meant to be inside your abdomen with all of your muscle and your core there holding everything together. And when that breaks down, even if the hole's not terribly big, if more of your inside, your intestines, your organs and whatnot get through that hole outside of the abdomen, when we push that back in, kind of loss of domain means you
Yeah.
can anticipate pressure on your heart, pressure on your diaphragm. And I kind of describe it to patients. I think the easiest way to think about this is if you have a suitcase and you go on a trip and you're there for 20 years, and then you try and shove everything back in that suitcase, you're gonna be jumping on it, pounding on it, squeezing it.
Yeah.
And it's not easy to get that to come back together. And that's kind of, I think for patients, the easiest way to think
That's
about
a
it.
great analogy. I may steal that. That's a
Yeah,
great analogy.
I'm sure
Yeah.
I stole it from somebody
I
too.
usually talk about like clothing, but I
Yep.
think suitcase is a good one because it's you're trying to really, you can only expand your abdominal wall so much, and you're trying to fit all the intestines back in. At one point it was back in, right? Well, so why is it at one point it used to be all back in, but once you burst this abdominal wall, that it's hard to go back in again?
Sure. So it's kind of like when you think about a hernia again, it's kind of like if you have a hole in your tire. Every time you stand up, cough, increase your pressure inside your abdomen, take a deep breath, whatever, you're pushing things out there. So every time that tire goes around, we
Mhm.
know that tire, the balloon of it just keeps getting bigger and bigger and bigger and bigger. And while hernias don't really pop,
Yeah.
the pressure in that balloon just grows. Why some people get really big ones and others don't,
Right.
it's not entirely clear why that is, but as it gets bigger and it goes out there, your body just is not used to having things back in that space. So it really does put a lot of strain on folks when we push it all back in there.
In your practice, you do almost exclusively hernia surgery. You're most well known for your giant hernia operations. I call them giant. Sometimes patients come to my office and they have a visible hernia, and they say, "Oh, is this the biggest one you see?" I'm like, "No, been bigger." I'm sure you get the same question, like, "Is this the biggest you've seen?" And
My,
you probably are like, Not even close."
my answer to that is thankfully for you, not in most
Yeah.
cases. I think no doubt about it. I tell everybody you definitely do not want to be special in my practice with a hernia, because typically, those are very, very challenging cases for the surgeon, but also for the patients
Yeah.
to get through all that.
Yeah. The next question has to do with what it really involves. Let's go to this next question. How is abdominal reconstruction different than a tummy tuck? What you do, how is that different from a tummy tuck?
That's a great question. So I think when you think about abdominal reconstruction, you think about tummy tucks and kind of everything in between there.
Hmm.
And you just kind of broaden it maybe to like abdominal core surgery, if you just put it in that broad category, which all this stuff kind of fits in. When we think about the abdomen and we think about surgery inside the abdomen, there's basically, and when I talk to patients, there's three parts that I need to be dealing with, and they kind of come in equal levels of importance. So the first part is the intestines. And in any operation inside your abdomen, it's really, really important that we deal with the intestinal side of it, because there
Right.
can be scar tissue where your bowels are stuck to different things and different hernias. And you want to make sure we don't have any holes in those, because those can create complications and leaks and whatnot. So
Right.
that's step number one. Then step number two is the muscle and the fascia that kind of give you your strength. And then step number three is the skin and kind of the subcutaneous tissue. So when we think about a hernia, there's a real hole there. And so we have to deal with the intestines, and then we have to do things to make those muscles that are no longer together come back together. And then we got to make sure we have good skin and soft tissue coverage. When you think about a tummy tuck, and most of the time, I think when people are mentioning that, they're really meaning more of like an abdominoplasty. But there's also something kind of on the other stream called a paniculectomy. An abdominoplasty is commonly in people with a disease called rectus diastasis, where there's not actually a hole,
Right.
but your six-pack muscles that everybody has that kind of hold you together can be stretched out just a little bit, commonly due to pregnancy, but other issues as well. And as that gets stretched out, you're not really at risk for a piece of intestines getting stuck through there, like the hole. But there are core issues that go along with that. There are back problems that go along with that. And for some folks, they are symptomatic. And so often in that situation, there is bringing that muscle and fascia back together. Typically in our practice, that's often done by a plastic surgeon. And often doesn't require mesh, but sometimes it does. And then the other part of a tummy tuck is that you remove a lot of the excess skin on the lower abdomen at the same time. So you kind of tighten back up the muscles and you remove some of the extra skin. And then there's another operation called a paniculectomy in some of the more complex hernias where really there's just what we call as a pannus of extra skin, not
Yeah.
necessarily with the diastasis, and we can remove that at the same time, but does add some morbidity to the operation. So all those things, we carefully decide what that is. But in every operation, there's always the skin, the muscles, fascia, and then the intestines that we break up and how we approach those.
Yeah, one of the questions is about this excess skin. So do you routine, when you have a hernia that's big enough that's constantly pushing out, it starts to thin out the skin. In fact, I tell my patients often, like the skincare is very important between now and when you eventually get your surgery, because the skin can thin out, thin out, thin out, and then you can get complications of this. You get ulcerations or breakdown of the skin. So that I tell them to put, some type of moisturizer on it, keep it moist, and then sometimes a binder helps reduce the pressure on the skin if applied correctly to reduce skin complications. But once they get to the point where you're operating on them, do you routinely remove the excess skin, or is that not necessarily a good thing?
Well, so it's really a case by case decision. It
Mm.
actually, you know, when I was younger, we used to spend a lot more time at the same big hernia operation trying to make the skin look perfect.
Yeah,
And what I've learned over time is that often when you do that, it requires extra incisions,
yeah,
extra dissection of the skin, and predisposes you to potentially healing issues, blood supply issues,
right.
infection. And so what I really now try and convey to patients is that I'm going to get rid of most of the extra skin with
Mhm,
a limited resection, fix the hernia, and then a
mhm.
year later, once everything is all healed up, if there needs to be some revisions of just some extra skin here and there, that can be done at a much smaller operation and lower risk of those complications. So I've tended to not do them at the same time with
Yeah.
few exceptions. And I think honestly, I think most patients really are more miserable from the lack of their core muscles in their hernia.
Yeah.
Once they fix that, they feel better and they're like, you know what, I'm good enough, let me go. And then some patients are like, no, I really don't like the way this looks, the scar, the whatnot. And then that can be done as a much less invasive revision of that scar tissue.
And how much of that nasty or thinned out or loose skin from the hernia repair does kind of regress and look back normal, or not so much?
Well, I think if it's really so actually, as we talked about kind of those three layers, this is one of the most important things for kind of the really what I like to describe as kind of the end stage of hernia repairs. And I think this is just to kind of touch on this
Right.
for a second, because I think that
Yeah.
there are a lot of patients who are told there's nothing we can do for you
Yes.
because when you look at them, it appears that there's not enough skin or soft tissue to kind of be left behind once you get rid of all of the thinned out skin, the nasty skin and whatnot. And so
Yeah.
this is one of the things that we do offer. And I mean, these are major, these are 15-hour operations, but they're possible for the right patient where we actually do what's called a flap, where we take tissue, skin, muscle, and blood supply from the leg. And with our plastic surgeons, we're able to actually do a flap where we actually can transfer that tissue and cover people's abdominal walls, almost like an auto transplant of muscle and fascia. And so that's really for kind of the extreme
Yeah.
case of there. But when we have to resect and there's not enough, when we know we're going to take off the skin at the big operation, and we know it's not going to come back together, that's where we sometimes do these things as combo cases.
Does that include muscle and fascia or just fascia?
Yep. Typically you can do perforator sparing. They're called an anterior lateral thigh flap, and it basically
Yeah.
just involves, if you think about your leg, your proximal, your femur, your thigh muscle, we can take basically the anterior compartment of that, and there's a
Well,
big blood vessel that it comes on, and we can actually plug it in the blood vessel inside the abdomen, and it
yeah.
really is, it's a flap that it's your whole anterior thigh. So it has a lot of skin, a lot of muscle. There's some morbidity to the leg for doing it,
Mhm.
but it really does kind of cover things up, and is, again, a morbid operation, but can really take patients who have been deemed, no hope at all, and give them a chance at a much better, quality of life, perhaps not normal, but better.
Yeah, so we have a comment about how this is so amazing that you're using your patient's own tissue uh, for as part of the hernia repair, and it should be the future. Do you want to comment on that? The morbidity is huge, and by morbidity I mean it completely changes your life in not a
Yeah,
good way.
yeah.
Yeah.
Well, so I think, and maybe this ties into like, what do we need to put people back together?
Yes.
Whether that's autologous tissue, whether that's mesh, what the mesh is made from. Because these are common questions that we get,
Yeah.
particularly nowadays when there's all the things on TV and whatnot. And I think, like my answer to that for patients to understand is that, nothing is perfect. I will usually say there's no perfect surgeon, despite how hard that is for us to admit. There's no perfect operation. There's no perfect patient. There's no perfect mesh. And all of these things, have risks and benefits to them.
Right.
And so, something like synthetic mesh does good, but in certain situations, it can cause harm too.
Right.
Uh, like you said, taking autologous tissue, it sounds great, but always remember when we talk about a flap, like what's that is, where we're basically moving tissue from a donor site to a recipient site.
Right.
By definition, the donor suffers some morbidity
Yeah.
and the recipient is supposed to suffer or is supposed to get some advantage to that. And so for these big autologous flaps, we really use them as a last resort
Yeah.
because as you mentioned, number one, they're not quite as durable as a formal mesh is, and we usually use them just for more of a coverage, tissue coverage.
Yes.
And number two is particularly for the big ones, while you'll get that coverage in your abdominal wall, you will have some weakness of your leg that particularly for certain patients can be life altering for sure.
Yeah.
So you're in many ways of everything we do in surgery, you're robbing Peter to pay Paul, and it's kind of the art of finding that balance for how hard to push for the right patient and when to not push that hard and kind of
Yeah.
when to have these conversations. Because I think that particularly for more advanced abdominal wall reconstruction, nothing is perfect. And it's just
Yeah.
about getting the best quality of life while trying not to cause too much harm.
But just to clarify, the risk of using, let's say, this thigh flap, right? One is that it won't take. So once you transfer it over, it'll die and you've lost it.
And
The
you've
other
lost,
risk is there are nerves there that you can damage. You're permanently probably not, numb along that area. Like you mentioned, it may affect your ability to use that leg like before. It may provide weakness. And then also the abdomen is not flat after that. It's a
no,
little bit, it's rounded
yeah,
because you've lost the nerves because it's no longer a functional abdominal wall, it's just a coverage, right?
correct. And that's really, really important to understand is that this is kind of for the end stage type
Yeah,
disease of somebody who
yeah,
really thought there's no way we're going to be able to kind of take care of this problem. But for the routine type hernias, and even for some of the more complicated ones, as you kind of pointed out, the morbidity of that is not worth the potential advantage of it being autologous tissue.
right,
Unfortunately, once you have a hernia, your autologous tissue isn't where it should be, and that's the problem for whatever reason, whether it was some technical issue with your operation, the way you heal, the quality of your fascia, bad luck, an infection, um, you're left with your tissue is not back together. So now there will always be tension there, more tension than there was before. And that will always kind of create this dilemma of what do we need to do to get it to stay together and heal for the second time in an area that's kind of already proven that it doesn't want to be together.
yeah. So I'd like to just kind of keep on this topic because there's a lot of concern that we are overusing mesh. I agree that we are overusing mesh. I think, for example, a 1 centimeter belly button hernia in most situations should not need mesh, although many surgeons do put mesh in a 1 centimeter hernia. And however, for a 20 or 25 centimeter hernia, the width of my shoulders, if the hernia is that big, the opportunity to do a tissue repair that person's already failed the fact that their tissue is just not healthy enough to withstand any operation. So they need some type of mesh. And mesh can be anything. Mesh can be a thick, heavyweight polypropylene, or it can be um, something like more biologic, less synthetic. We have a lot of technology that's come about that is not, there's not one type of mesh. There's at least like 30 in the market right now, where you can choose. So this idea that all mesh should be banned means every single patient that you do probably has no option or has a horrible option. I'll give you an example. I had a patient who was in a horrible car accident, almost died, lost his spleen, his whole belly was filleted open multiple times, like compartment syndrome. So he came to me after basically he was, after he was alive, but he had all these fistulas and he had stool, basically shit coming out of his belly. And his entire life was to wear gloves and just scoop out poop off of his belly. Long story short, I fixed him. But he had so much operations before that I had to do exactly what you said, the flap. So he didn't have enough, he had lost muscle from all these mesh, he had mesh infections and fistulas. So he had lost so much tissue, I could only bring him back to like this much. And I couldn't, there's like a gap. And otherwise, if you don't close it, like your intestine will fall out. So we did a flap of muscle, which sounds interesting. You can use muscle from your butt or your side and bring it over, or your leg and bring it over to a different place. But that muscle needs to be fed, and it's fed by the nerves. And if you cut the nerves because you just took it off of where it originated, it's just a piece of, like, it might as well be fat. There's no function to it. And he got so depressed by the fact that he used to have a flat belly. Now it's true, shit was coming out of it. Sorry, stool was coming out of it. But it completely destroyed his life. The fact that he now had a round abdomen. And people who make comments that are all inclusive, mesh should be banned, don't understand that you could potentially make every single patient of yours be completely maimed if they don't have the options of different types of mesh. And you're the specialist, you will figure out what the best mesh is. But these giant hernias, they became like that for a reason. What are your
Yeah,
thoughts?
interesting. Yeah, so listen, first of all, I agree with you. I think that you know, I think the general statement of do we overutilize mesh is true.
Yeah.
And I think that, it's probably important for everybody to understand, like, how did we get here? Like, why do surgeons feel like they are using more mesh? Well, it's because when we didn't use mesh routinely, hernias failed. And so I think that, and they came back. And so I think that, from the surgeon's perspective, we want to help people. We want to make the hole go away, and we want to do the best thing we can. I think that, I think we kind of go through a period, and this is how surgery works, is nobody does anything, then everybody does everything. And then you kind of wind up somewhere in the middle. And I think that's kind of what we're learning now. And I think we have a lot more to go to figure this out. And I think, everybody has to pitch in, because as you said, the answer isn't binary and it's not simple. The answer isn't everybody should get mesh, and the answer isn't no one should get mesh.
Yeah.
So the only way to really figure this stuff out is for all the stakeholders to really engage in this process. And I think probably in 20 years in this field, what I've feel like the most is a lot of people feel like a hernia is kind of like you get the operation, you're done, and for the rest of your life you never have to think about that again. And I think one of the things that we're learning over the years is, not just for giant hernias but for all hernia surgery, is it's a little bit more like orthopedics, where when you get your back or you get your knee or you get your hip done, they tell you day one, this is going to last for 15 to 20 years and you're going to need it done again. And so we all need to participate in kind of furthering the knowledge. I think surgeons need to participate and put their data in registries and whatnot. I think industry, the makers of mesh, need to participate and follow these things carefully. And I also think patients need to engage in this and say, we really need to come back for follow-up. We need to answer these questionnaires. We need to get this information out so that we can know what we're doing right and what we're doing wrong. Because there's no question in my life, the more follow-up I have, the more people I see long-term, the more humbled I am by thinking, wow, I'm not as great as I thought I was, and we got to make this better. And that's where true improvement in this field comes from, is kind of looking at things and saying, what can we make it better? And if it's, improving patient optimization, if it's improving surgical technique, if it's finding the right mesh. And the thing about mesh, I think the hardest thing for people to kind of understand about mesh is, while it's very easy to kind of point the finger when something goes wrong for the patient. I'm sure surgeons are guilty of this as well, is that, when the mesh goes in, there's a lot of technique and skill in how that happens. And even in the best of hands, things can happen. There's no question about it. But the way that all these things are done matter, and they probably matter to the outcome for that. So when things go wrong with a mesh, we really need enough information to know kind of how was it placed, what was the technique, what type of mesh was it, and all those things, so that we can get a large enough experience to then be like, okay, this is a real signal. We have a problem here, and we all need to change.
Right.
And a lot of things have to happen, I think, for that environment to take hold. I think we're getting some momentum. And I think actually, just the fact that we're here, we're having this conversation, there's patients, there's people listening, and the thousands of people who participate with you is so important, because it just gets the message out there that, look,
Yeah.
we don't have all the answers, and we all have to participate to get them.
Yeah, it's as scientists, we know that we don't have all the answers, but it's sometimes hard for people that are like victims to accept the fact that we're operating on people without having all the answers.
Well, that's, I think it's so important for people to realize is, that is, at the end of the day, as a surgeon, you still have to come to work every day, and you have to take care of patients. And
Yeah.
in our world, there's not always going to be enough evidence to be 100% certain this is what we should be doing. And I think that level of honesty with patients is important to understand. Hey, look, I am doing today, February 2nd, 2021, what I think is the best thing for you. And one of the things we do at the Cleveland Clinic, I mean, we have 10 ongoing randomized controlled trials right now. And we really try, about 70 to 80% of the patients that we operate are involved in some clinical trial. And one of the things we talk to patients about is, this is what we're here to do. And we're trying to find the answers of what
Yeah.
works and what doesn't.
Yeah,
And
absolutely.
whether it's technique, mesh, whatever. And I think that kind of passion to figure that out, and then make a change. Because I'll give you one interesting. We just completed a paper, and we just actually submitted it.
Yeah.
It looked at two different kind of meshes, like a heavier weight mesh and a medium weight mesh, where people kind of felt like, the heavyweight mesh, you're going to be able to feel it, and it's not good, and it hurts for ventral hernia repair. And so the patients were blinded. At 1 year later, we asked the simple question, do you feel your mesh? Yes or no? And amazingly enough, there was 175 people in each arm, and it was to the exact same number of patients with the two meshes said they thought they felt the mesh. So I think it just shows there's nothing perfect. And I think that this, we need to get the information. We need to ask the patients and understand what they feel and what matters to them.
What is your thought on biologic mesh? Biologic mesh, for those of you that are unfamiliar with the term, is basically mesh, which is like some type of product that's used to bolster or bridge or kind of help cover or a hernia. It's biologic in that it's not synthetic, and they're almost always, yeah, they're always absorbable. So, what are your thoughts on biologic mesh, and then cross-linked or not cross-linked, especially in like, does it matter? And especially in a patient who's already had a prior mesh infection, probably propylene mesh infection.
Yep, great question. So maybe I would, a couple maybe different perceptions on the biologic mesh. So my biologic mesh, what it basically means is that it starts from biologic tissue. So it could be pig skin, it can be cow pericardium. There's a whole bunch of different, sheep stomach and whatnot. that's where it starts from. But I always think it's important for people to understand, because it is a common thing to think, okay, and the term biologic is certainly more accepting, especially nowadays, than synthetic mesh, and the fear that goes around that. So I think one of the things I always like to tell patients is, be careful about thinking something's biologic, because we are very good at taking biologic tissue and then making it synthetic. And the perfect example of that is actually if you terminally cross-link pig skin, so it starts off as biologic, then you make it into actually leather that we would all consider is something synthetic. So the idea that it's biologic, so it's safer, it's probably a stretch. You just need to be careful. Now, just like everything, like we said before, there could be advantages to making something more synthetic. It might make it a little bit more durable. So my general concept about biologic mesh is, I think in today's world right now, I think that we don't have enough information to know, uh, is it better than synthetic mesh? Meaning better, meaning less recurrences, less pain, less infectious issues. It certainly has been heavily marketed as that, but there are a couple randomized control trials. In fact, I'm one of the PIs. It's about to be finished April 1st. It's taken me 8 years, and we'll submit it for publication. So we're about to analyze all the data where we put biologic mesh versus a synthetic mesh in kind of contaminated, challenging cases, and we'll see what happens at 2 years.
Yeah, fascinating.
So I don't think we know the answer to that, and I think that it's a fair conversation to have with your surgeon.
Yeah.
In my practice today, in today's world, I don't use a lot of biologic mesh, because I feel like if it's okay to use a mesh, I will use a synthetic mesh. Otherwise, I might not use a mesh that day and come back another day. And then as far as cross-linking goes, like I said, I think there are theoretical advantages to it, and that it might make it a little bit stronger, but there's also some potential disadvantages that it makes it a little bit more synthetic. And so if you want something less synthetic, and that's why you chose it, you might not be getting those properties from it. So, but unfortunately, and I'll kind of revert back, and I think this is so key. This is where we really do need head-to-head trials where we can look at this stuff in kind of comparable patients.
Yeah.
Say, is it really all just technique? I mean, is all that matter that you have a good surgeon put it in, and it doesn't really matter what your mesh is? Or are some meshes, no matter what, gonna cause harm, and we need to take all that? And kind of figuring all that stuff out requires time and engagement and investment. Everybody.
Yeah, we're not born with all this knowledge. We have to learn from experience. Yeah, I think those of us that used biologics in its early stages, I was one of them, has either stopped or really, really reduced how much biologics we use, because the results are not there for it.
But it is appealing, and maybe I'll just tag on it, because that's the other, like the absorbable synthetics are like the newer ones out there.
Yes.
And I think, like, in this world where there is a kind of overwhelming fear of synthetic mesh, and as we said, for good reasons in certain cases.
Yeah.
That there's a big push that, like, well, if you don't want mesh, why don't you have this? And I would just stress that, again, we don't have a lot of understanding of these things. We don't really know what happens long term. And like everything, there will potentially be some advantage to not having a permanent mesh in there.
Yeah.
But there might be some disadvantages in that hernias come back, they become more complicated. And I think we just need to kind of wait that out.
Yes.
Because my biggest message to patients is, listen, whatever mesh we choose here, that's a little bit more like the golf club that drives the ball. Like, it's not really the club that's making the ball go far. It's the person swinging the club. So a lot of that technique, and you got to trust the judgment of the person doing it. And no one mesh is going to make it all okay for you. And it's unlikely that any one mesh is going to be horrible. And I tell most people, look, if you find a surgeon you like, and they're doing a good operation, they're experienced, just do whatever they do best. And if it probably doesn't matter what they put in, you'll be okay. And if the mesh isn't put in right, it probably doesn't matter what the mesh is made of. It's probably not.
You mentioned synthetic absorbables. One of the questions is, what is your opinion on phasics ST.
Yep. So I don't have any clinical experience with that. So I can't comment on my own personal experience.
Yeah.
I've certainly had cases where I've operated where it's been there before and whatnot. I'm a little bit more of a hard line. I don't ever try a new mesh unless it's involved in a trial because I just feel
Yes, same. Yeah, I agree.
I think that there are kind of concepts of it that I think are very appealing. And I think the idea of how long do you really need the mesh to be there is a fascinating question.
Yeah.
But I think that the problem with all of this stuff is just hypothetical, right? And
Yeah.
you need to do 5-year studies to say, okay, if I put this mesh in, it might look okay at 2 years, but at 5 years, it's all coming back, and people won't be happy with that. So I think in today's thing, I haven't got it in my practice, but I think that it certainly has some appealing characteristics. But I really think we need long-term data before we kind of.
Yeah, there are a lot of absorbable meshes, and they're typically absorb either within 3 or 4 weeks or around 8 or 9 months. At least that's what the theory is. The synthetic absorbable Phasix ST is marketed to absorb around 2 years, 18 months to 2 years. The thought being that that's really all you need, and then your kind of tissue strength and scar tissue kicks in. We don't have the 5-year data on that yet. And I believe the 3-year data is kind of iffy. I think it's like something like, correct me if I'm wrong, like 20% recurrence.
Yeah, it was pretty.
So
It's pretty. The biggest thing, my biggest like kind of theoretical concern with it is we know if we put a permanent synthetic mesh in there, when you really follow these people out to 5 years, recurrence rates are higher than all of us wish they would be. So if a permanent mesh is failing at 15%, 20% at 5 years, then one that goes away, it likely isn't going to be better than that. It's going to
correct.
be the same or potentially worse. And the idea is just how much worse is it? And I mean, nobody knows the answer to that. If it's the same, then I think, well, if you don't need something permanent in you, all the better.
Right.
But if it's twice as high, then that might be a bridge to synthetic mesh down the road, which isn't necessarily probably worth another
Yet
operation.
another operation. Yeah.
We just don't know.
So the operations you do are quite rigorous on you and also on the patient. The question is, how often do you need your patient to go to the ICU or be left intubated after surgery?
So we've actually done a lot of work around this because this is kind of one of the big things is always to kind of understand this and get the right resources available and plan it out. So the reality is it goes back to that first question, which is loss of domain. And can you
Yes.
predict once you push everything back in, how much that is? So we do some basic tests in the operating room. We somewhat eyeball it before surgery based on the CT scan and the exam and just kind of the general health of the patient.
Hmm.
But I would say 7 or 8 years ago, I would probably say maybe 50% of my patients went to the ICU
Yeah.
post-op. I would probably tell you now, just because we've gotten probably better at selecting patients, better at optimizing, more efficient at doing the operation, I would probably say 10 to 15% of
Okay, that's
my,
great to know.
yeah, which
Is
is
that
probably
because
lower than most
is
people.
that is that because of you and your experience, or now you have a team that's more well versed in recovery?
I think, well, a couple things. I think number one, I think it's like everything when you kind of learn as you go. I think one of the things that I did learn over the years is when we were much more aggressive at keeping people intubated because we were afraid they weren't going to be able to breathe and whatnot.
Yeah.
And while that sounded like a great idea, there's a downside to that, is particularly if you're giving people paralyzing medicine and being in the ICU or the ventilator affects their lungs, that we weren't necessarily helping as many people as we thought.
Yeah.
So then we kind of refined it to predict like what pressure we could take the breathing tube out and not go to the ICU.
Hmm.
And so once we kind of figured that out, we were able to refine it and predict pretty well with that. And I think the other thing is just like everything, after you do, 1,000 operations of something, you get more efficient at it. It takes me much less time in the operating room. So they're getting, several liters less of fluid. It's less anesthetic, and we're just more efficient at
Yeah.
this operation than I used to be.
Yeah.
And I think that helps as well. And the other thing is I'm probably good at knowing who's not going to tolerate this operation and maybe
Yeah.
say no to those people up front, or having them lose weight, quit smoking, and all those type of things. improve your outcomes.
We do have a question about weight loss coming up. Before that, a lot of really positive comments. OMG, music to my ears. I'm so impressed by two brilliant surgeons who are so scientifically rigorous
That might have been my mom. That
and
might have
yet
been my mom.
humble. Your mom says hi. Next question is about Botox. Do you use Botox for your patients? This is a technique that helps relax the muscles before surgery to help close these big defects. If so, how many units, and does insurance cover the cost?
Yeah, great question. So I don't use Botox. I did maybe like 10 years ago. And I kind of one of those things like we just talked about where I kind of got better at the operation, better understanding how to do these things and close these patients. I have completely stopped using it. I know that it's kind of a bit trendy right now to do it.
Yeah.
It's very expensive.
Yeah.
And it's a lot of expense that typically is borne out on the patients because again, I don't do this anymore. I know there's some consideration of whether or not insurance covers it. I can tell you at my hospital, insurance would not cover it and the patients would have to pay for it.
Yeah.
It's about $3,500 for just the Botox because it's about
Yes.
50 units. So I feel pretty strongly that, it would really have to show that it's better than my normal. And so I can just give you, we're actually just submitting a paper with 1,300 of these type of cases. And we close about 95% of patients without any Botox. So you're down to only 5% of people can't be closed.
Okay, that's
And the
great.
problem is those 5% of people, the hernias are so big that Botox really isn't going to help those people. So we're just actually trying to get started a placebo-controlled double-blind trial where we
Yeah.
blind the surgeon, we blind the patients, and we give a placebo or Botox to a certain group of patients who are high risk for not closing to see
Yeah.
if in fact it adds something. Because this is one of those things that again, like we kind of, it makes intuitive sense, but it's a lot of cost. It's a lot of
Yeah.
time. It's extra visits for the patients. And so I really do think that we really ought to study this carefully before we just say, hey, do it. And I guess my biggest concern about Botox is often I think that people who are less experienced with abdominal wall reconstruction might use it in an attempt to try and make the abdominal wall reconstruction easier. And it's
Yes.
not really going to change that. So you still, on the day of surgery, you're still going to be able to go there and put people back together. And so, again, an area that needs to be studied, but I don't do it anymore.
Okay. One question about if someone's already had nerve injury or a nerve severed from previous abdominal hernia repairs of the ventral hernia, is there any way to repair a recurrent hernia without mesh? And would a flap be something to consider?
Yeah, flap, probably not. Flap, just to kind of reiterate it, that really is the morbidity of that, unless we're talking about just an absolute massive hernia, we don't typically go for flaps.
Yeah, it's very uncommon.
And as
Yeah.
far as the nerve and the mesh and everything, like, that really does require kind of sitting down on a case by case basis and understanding kind of what happened in the first operation. Because the reality is a lot of nerve injuries are technical, not mesh related, meaning
Yes.
that you got lost, you were in the wrong plane, or there was just a nerve you had to cut, and there's scar tissue around that nerve. So while the mesh is kind of an innocent bystander, it's not necessarily the issue. And there's no question that there are nerve injuries that occur. So kind of understanding that if it's truly a nerve problem, then there are often things we can do to address the nerve, and then addressing the hernia is kind of a separate thing. And once it's a recurrent hernia,
Yeah.
I'm hard pressed to say you wouldn't need a piece of mesh.
Yes.
There's no question in today's world, we get people who are just like, I just absolutely don't want it. And I would say, and I'm sure you've seen this in your practice as well. There are rare people that for just whatever reason that I don't know why, just respond to mesh differently than many other people.
For sure.
And whether they get an incredible inflammatory response, whether they
Yeah.
get a lot of scar tissue, or
I have
whether,
a fair number of patients with that where
yeah,
we presented at the meeting and we're writing up our experience because it's a very unique but challenging set of patients.
and in fairness to a lot of people, I don't think that number is incredibly high.
Super
I think
small.
the people who have it are very devastated by it.
Yeah.
And I think that what's hard for us as surgeons, and me in particular, and a lot of this more fits around the inguinal world, is you can have a mesh that looks fine, but it's causing pain, and kind of how to bring all that back together and kind of
Yes.
figure out what we're doing. So I think when people and just as a when somebody, let's say, just make it easier, when it's a primary hernia, no prior mesh or anything like that, and the primary complaint is pain, then I think it's important to step back as a surgeon and for the patients to understand that your pain might not be related to your hernia. It might be just related to damage that was done that gave you this hernia. And
Right.
so fixing the hernia might not make that better, and
Right.
kind of make sure you understand where the pain's coming from at first. Because then otherwise you get this terrible vicious cycle where essentially, you had somebody with pain in a hernia, now they have mesh and pain, and then trying to figure out where all this stuff started and how to fix it. It's really challenging.
Yeah. It's a very, we had at least one entire session on Asia syndrome or Schoenfeld syndrome, which is a
Yep.
true systemic reaction to any implant, mesh among them. And it's challenging. And we're working on figuring out how to at least either treat them or be able to predict. We're not getting into anything very
Yeah,
good yet. It's very
I think
rare, and
yeah, I
the
think the
studies we
hardest,
currently have are not good.
I mean, I think that the hardest thing is identify those people,
Yeah.
even after they get it, and then figure out like what it's going to take and kind of what is a reasonable expectation of making folks better.
Yeah. What are the risks of sutures pulling out or the muscle tearing when suturing muscle? And can the risk be reduced by suturing technique or suture selection?
So I would say anytime you have an operation, when they close back up your muscles, and you don't have a hernia, but they just close you, there's
Yeah.
great data that technique really matters.
Oh,
And
yeah.
really, for one of the very few things I would say is that, we know that if a technique is done with kind of, we call them small bites very close together and it's time consuming, that improves outcomes.
Yes.
Now, when we talk
Small
about,
bites technique. Uh-huh.
yep, and that is kind of one of the few things in surgery where there really are great trials that kind of support that.
So you
Uh,
use that regularly when you do your fascial closure?
yep, for not hernia patients. When you're fixing a hernia,
Yeah.
um, I think so. If you're going to say, well, let's fix a hernia without mesh and just use sutures. Well, we know that there's a hole there, so there's tension, and when you pull things back together, we do know that the sutures typically won't hold together. Although I will tell you, one of the next trials that we do want to do at the clinic, which I think would be an interesting trial that I don't think has ever actually been done, is for an incisional hernia, a smaller one, like maybe 5 to 7 centimeters or less, that actual small bite 4-to-1 closure
Yeah.
versus 4-to-1 closure with mesh, and see if potentially, as we kind of said before, for the smaller hernias,
Yeah.
maybe if you really suture it the right way, is that enough? That's never actually been done. And I think that would be an interesting kind of mesh versus no mesh
Yeah.
type trial to see, but we don't know the answer to that yet.
So I have a unique population of women who want or are good candidates for tummy tuck and are willing to, I practice in Beverly Hills. I'm in what's called the Golden Triangle. I believe there's more plastic surgeons per square foot in my Golden Triangle than anywhere else in the world. I believe that's a true fact. Um, so tummy tucks are not, you know, a lot of people have tummy tucks. But what I'm learning is, because I have a lot of patients who have hernias and or need a tummy tuck. So we're working on using the tummy tuck, the plication, as your biologic to close the hernia. So you close the hernia and then you plicate the fascia on top of it. Obviously done with good technique. I have excellent plastic surgeons available to me, and I work with them. And so we have a series of patients now that if they didn't get the tummy tuck, I would have done a mesh repair. Incisional hernia, right?
Yep.
Incisional hernia is by definition 50 or 60% recurrence if you don't use mesh. So mesh is indicated. but I haven't put mesh in them. Instead, they had the tummy tuck because it was within a diastasis, or they had a previous tummy tuck that needed revision. And, knock on wood, it's been, I think the latest one's like 4 years, and they're doing really well. So
Well, there's no doubt
it's
about it. If you watch a plastic
interesting.
surgeon close a tummy tuck, it's usually 2 layers, inverted,
Yes.
and
Yes.
they're meticulous. And so, as we said, it's not the club, it's the person swinging the club.
Yeah.
And so I think that there's no question about it that not, people typically getting tummy tucks tend to maybe be younger, a little healthier, and whatnot. But there's no question that
Yes. Correct.
for some of the smaller things, it does make me wonder. Now, for the really big things, and I think that's
No, no,
important.
no, no. It won't for the big things.
Look, when you had 2 or 3 or 4 failed hernia operations and the hernia is
Yes.
really big, at that point, we don't have
Yeah.
any other options. You're going to need a big operation with a
Yes.
big compression, and it's likely you're going to feel better after that. But
Yes.
but the earlier stage, and I kind of liken it to like I feel like I want to tell people, hey, look, same thing I think we talked about is for umbilical hernias. If you have a 1 centimeter umbilical hernia, I tell everybody, let me just stitch it up. There's probably a 90% chance you'll never need mesh.
Yeah.
And if you don't need mesh, you don't want mesh. And then if it comes back, then we can go ahead and put a piece of mesh. So I think
Correct.
perfectly fine. It avoids a lot of the stress and the concern and of what's happening with mesh, particularly in young people. So I think that for the small umbilicals, you should just stitch them up and see what happens.
Correct. And I exactly, part of that consent in agreeing to a non-mesh repair is that if it fails, right, then there must be a discussion where you're going to need mesh.
Yep.
Obviously not in patients that are you know reacting to mesh, but these are the typical patient. um I'd love to know your behind the scenes preparation in repairing hernias that are of this great magnitude. You mentioned some of them can be 15-hour operations. I think typically they're more than 3 or 4 hours of these really long operations. What is a toll on you as a surgeon before and after? And then also, what rigors do you put the patient through before they're eligible to have such an operation?
Sure, sure. So for me, I've got a sore back and I've got a sore shoulder. There's no question about it. I think one of the interesting things about this operation, particularly when you do it open, is that there is no what we call a retractor, where there's kind of something that normally we put something in that kind of holds everything open. In this operation, it's really just you as the surgeon that kind of has to get exposure to do this. And that's actually probably one of the biggest reasons that we do require weight loss before this operation, because if you're too heavy, we just can't move things out of the way to see what we need to, and it's just too difficult on our back. Now,
Right.
knock on wood, I have not had back or shoulder surgery yet, but I sense that I will be there one day soon for that. But there's no doubt about it. It does take a strain. I think it also, truthfully, these are big operations on people who often have a lot of other illnesses and whatnot. And there's a mental strain of just worrying about patients and making sure they're doing okay. And so I think that's kind of my segue into it's a lot for me. And these are, long cases, a lot of stress and effort and whatnot. So I do want to make sure that the patients understand what they're signing up for. And probably the biggest thing that I focus on is trying to have people understand that we are a team during this, and the teamwork starts the minute I meet you. And so your role as a patient on that team starts getting ready before surgery. And that's making sure that you've lost enough weight so that it's safe. And there's no magic number, but it's just doing the best that you can. Trying to quit smoking if at all possible, making sure that your diabetes is under control, and really taking good general health, trying to walk and get your heart and lungs going to undergo that. And so you put that effort up front. And then once you go to sleep, it's on me. And that's for me to do my
Yes.
A+ job and bring all that. And I tell everybody, I'm like, listen, if it takes me 10 hours to put you back together, I'm not going anywhere. I'll be there with you. If
Yeah.
I'm tired, if I don't like my nurse that day, if I got in a fight with someone, if I got to get to my kid's basketball game, I will be there until the end. So my expectation is no excuses from anybody. We're all in this together. We're all going to do our best. And that goes for post-op as well. So I think a lot of this is making sure that you're I tell patients also, like, look, when you leave here, you're going to get your surgery day. Put that on your refrigerator, and
Yeah.
that is your day to get your life back together. So you train for that day, and when I'm there, I will. That's how I see this: is I'm here to make you
Yeah.
better. So
Yeah.
you got to see it too, and it can't just be put your arms out and say, "Hey, I'm at the Cleveland Clinic. Mike Rosen, take care of me," because that'll never work, and it's got to be a team.
Yeah, and on that note, what do you do in terms of weight loss recommendations? One patient said their doctor told them they have to lose 30 pounds before they can have their hernia repaired. Is that something that, how aggressively do you get involved? Do they do medical weight loss, surgical weight loss?
Yep. So this
How
is a,
much weight do they have to lose? And in patients that have such huge, that are disabled from their hernia, how do you get them to lose weight?
Yeah, so obviously, obesity and being overweight is a very difficult disease, and I think that we're learning
Yeah.
that there's no easy fix for that. Bariatric surgery hasn't been an all fix. Medical weight loss isn't an all fix. I think that this is a really, really tough problem to deal with that I have fought for most of my adult life as a surgeon, and so I think to answer the question, I don't think there's a magic number, but we have looked at this a lot, particularly in our quality collaborative. And the bottom line is we look at what's called your BMI, which is your height and your weight, and gives us kind of a general number. And we want it to be about in the mid 30s, which is about where we think things are safe. That's, again, it depends on where you start. If you start at 50, it's unlikely you're going to get down to the mid 30s. So we want to see effort. And so what we have done, we have a whole program. We actually have a virtual coach that you get.
Okay.
Interestingly, 75% of people don't actually call that virtual coach back, just because there's a lot of issues that
Oh
go
my
along with it.
God. Yeah.
We have a great bariatric program where we'll offer people to get bariatric surgery if it's possible to do like a sleeve before this, which also can be difficult and not doable.
Yeah.
Now, we typically recommend, we have a whole medical weight loss program, which is like a protein sparing fast. But ultimately, I think that I just like to stress this for patients is this is your chance. And one of the things so most people who come to see me who've had complications, a lot of them revolve around infection. And they often think of them more as rejection, but it's really an infection. And the best way to reduce your chances of
Yes.
infection is losing weight. And
Yeah.
so I want them to understand that, hey, look, I'm going to do a lot of different techniques in the operating room to try and reduce infection. But what I need you to do is get ready before surgery. So sometimes it's 30 pounds, sometimes it's 50, sometimes it's 10. A lot of times it's just kind of understanding mentally as a patient that, hey, I'm about to potentially have a life-altering operation. This is not go to the hospital, go home, and I'll never think about this again. You might think about this for the rest of your life every day if this doesn't go well.
Yeah.
So get yourself ready to go on that trip as best you can. And that's kind of embracing, hey, I have a disease. I got to do what I can to get ready. And so we
So
offer all
true.
that support. It's not perfect and everybody doesn't lose weight, but we certainly try and do it.
So true. So a lot of people are thanking you. This is a very inspiring talk for them. We have one regular on Hernia Talk who I love, and she said she's looking forward to contributing as the patient perspective on the ACHQC Patient
Welcome.
Advisory Committee. So thank you, Dr. Rosen, for starting the quality collaborative. Do you want to end with that and tell
Sure.
us a little bit about it and what
Oh, yeah.
patients can do?
Absolutely. So I'm the medical director and the co-founder with Ben Polish, who I think has also been on this before as well.
He's been on our show.
Yeah.
Yes.
So basically, we started this about 8 years ago now, and it's basically a way to try and bring all of the stakeholders together, and that is the FDA, industry, surgeons, and patients, all to get together and try and understand what do we really need to do to improve outcomes from a good place. And so
Right.
I think patients are critical. And I think we have a whole patient advocacy committee, which I'm excited to be a part of. And I think that
Yes.
Harriet Schwartzman is the lead on that. And I think that we're having our upcoming summit meeting in March, where there will be patients who are there to kind of talk and interact with us. Because I think that perspective is key. And like everything in life, when there isn't communication, there builds mistrust, and people don't understand what the other people are doing. And
Right.
even though everybody might be trying to do something for the right reason and improve outcomes, if people aren't communicating, the vision is not aligned. So we collect data, we reach out to patients, we're trying to engage and try and figure out, quite frankly, what we're doing right and what we're doing wrong, and learn from each other. So it's obviously, that's one of my passions. And it's certainly been a great 8 years. And I'm glad that we're finally kind of bringing in the patient perspective. And I think this is our next big leap forward, is to kind of leverage that relationship to understand what's going on.
And I encourage patients to not only find surgeons that are members of this quality collaborative, it's achqc.org. So surgeons like me who have chosen to be involved, every single patient we operate on that is hernia related gets plugged into this. And that means that I care about what happens to my patient years down the road. I'd like to learn more about my own patients and also others. So I highly encourage that either you find surgeons to take care of you that already have that commitment, or if you have a local surgeon who doesn't, please tell them to go and become a member. I think it's
Free.
Is it free? Yeah, it's free.
Totally free. In fact, I would echo what you, the one thing I would just say is to me, what one of the things about the quality collaborative I think is important, particularly for patients' perspective, and I think it's important to kind of put this out there, is it's just like sports, athletics, everything. There really are, there's going to be a spectrum of surgeons across surgery. And so one of our goals at the collaborative is not necessarily to say we're all going to be the same and have the same outcomes.
Right.
But what our real goal is to say that we want to make sure that every single surgeon is the best possible surgeon that he or she can be by going through this process, looking at your outcomes, looking at your data, making sure you're doing things right. And so to me, what it really is a stamp of is you have a surgeon that after every one of your operations, they're going to sit down for 2 to 3 minutes,
Yeah.
and they're going to say what happened, and they're going to engage long-term. And so to me, it's almost like the Better Business Bureau stamp. What you go in, you say, and so I tell all patients, hey, look, when you meet with a surgeon for an operation that's going to have a device that's put in you for the rest of your life,
Yeah.
you want to make sure that that surgeon is invested in what's going to happen to you for the rest of your life. So I think that's really key. And I think for patients, that's certainly something to ask and say, hey, if you're not, then what are you doing to track your outcomes, and why are you not doing that?
Yes, absolutely. And it's the only outcomes database that is focused on hernias. It asks so many specific questions. What suture did you use? What mesh did you use? What size did you use? Tacks? What kind of tacks? These are all so key because there's so much chatter and concern and negative information about what we do as hernia surgeons because there's so many patients that have been hurt. There's a lot of them. It's not like hundreds or thousands, it's more than that. And so this is the only manner that I know of that can at least prospectively kind of track what we do and then look at the outcomes to learn. Because I personally will have, I don't know, 5 patients with a certain problem. But if there's 100 of me out there, we now have a database of 500 and we can learn much more about that. So thank you for doing that. Dr. Paulus was on this several months ago. It was really great because we also talked about his core health. And one of the resources on the achqc.org is this patient, and I give it the handout to my patients on like exercises they can do before, during, and after surgery from hernias. So
well, there's actually I'll plug this out there too.
Yeah.
For anybody's interested, particularly if anybody kind of has any abdominal wall issues or whatnot, we actually have a free app. It's on the iPhone or the Android. It's ACHQC, and it actually has physical therapy directed with pictures and videos of kind of how to rebuild your core after surgery and whatnot.
Yeah, I'll put the link on this on Facebook.
Yep.
Yeah. All right. What a great way to end the evening. Thank you for your time, Dr. Rosen. This ends us for yet another Hernia Talk. We're reaching our 1-year anniversary pretty soon because we started this at the beginning of the pandemic. Thanks everyone who follows me on Facebook at Dr. Towfigh, as well as on Instagram and Twitter at HerniaDoc. Tonight, I will make sure that you all get the links to watch this and share it with your friends on YouTube, on my YouTube channel, and I will see you next week with yet another great guest. Very excited to share it all with you. And thank you for your time. I do appreciate it. Hope to see you soon.
All right. Thanks, everybody. Be safe.
Bye.
Thanks for
Thank
having
you.
me.
Thank you. Bye.